Welcome to the MS&Me Radio Network, a division of the Multiple Sclerosis Global Support Network. The following program broadcast is an original creation by the broadcast entity. Discussion within the following broadcast should be used for informational purposes only and is not a substitute for professional medical advice or consultation. Before considering application of any broadcast content in the following program, please consult your healthcare provider. If you feel you are having a medical emergency, please contact your local health services for immediate assistance. MS&Me Media and the Multiple Sclerosis Global Support Network do not guarantee or warrant the accuracy of information in the broadcast to follow. The Multiple Sclerosis Global Support Network provisions broadcast services to program hosts. Information discussed in the broadcast does not necessarily reflect the views, opinions, or goals of the network and are solely those of the show broadcast host. Should you wish to host a broadcast, please visit our website at msmemedia.com and submit a request to become a program host. We thank you for listening to the MS&Me Radio Network. Enjoy the show. Welcome to the MS&Me ECTRIMS 2017 review. I'm your host, Erica Lyons-Richardson. The 7th Joint ECTRIMS-ACTRIMS Conference was held this year in Paris, France. It was 4 days of exciting clinical and research advancements. With more than 10,000 delegates, this was the largest conference in multiple sclerosis so far. For those new to the multiple sclerosis community, for a quarter of a century, ECTRIMS has served as Europe and the world's largest professional organization dedicated to the understanding and treatment of multiple sclerosis. The European Committee for Treatment and Research in Multiple Sclerosis, or ECTRIMS, is a nonprofit organization and an independent representative European-wide organization is devoted to multiple sclerosis. ECTRIMS works with researchers and clinicians of its member countries with other organizations that share similar missions and objectives on a worldwide scale. They create networking and collaboration opportunities. The ultimate goal of ECTRIMS is to improve basic and clinical research and clinical outcomes in multiple sclerosis. This year's program was full, starting on Wednesday, October 25th, with a day including 18 teaching courses on topics across the whole of the MS spectrum, as well as 2 nurses sessions emphasizing the importance of MS specialty nursing, both for clinical outcomes and for research advancements. The main conference started following a day with an unexpected cabaret performance for a little local culture. This was followed by a lecture by Dr. Hans Lassmann from the University of Vienna that succintly explained the advances made in clarifying the pathophysiology of this inflammatory disorder. The insights into the phenotype of the brain infiltrations by T and B lymphocytes, and the clinical implications of these findings and further questions for research. Over the next 3 days, attendees are heard about clinical and scientific advances in adult and pediatric MS, as well as other demyelinating conditions such as neuromyelitis optica spectrum disorder, known as NMO. The most important findings presented at this year's ECTRIMS-ACTRIMS meeting that will eminently affect clinical practice are as follows. The 2017 revision of the McDonald criteria. This was presented by Dr. Jeffrey Cohen from Cleveland Clinic in one of the most well-attended sessions, followed by an in-depth presentation of the implications of the new criteria for clinicians by Jeremy Chataway from National Hospital for Neurology and Neurosurgery. The researchers here reveal key revisions to their McDonald criteria for diagnosing multiple sclerosis. Chief among them was the use of the oligoclonal bands, the OCBs, to make a speedier diagnosis, as well as including both symptomatic and asymptomatic lesions as evidence of dissemination. Revisions co-chair Dr. Jeffrey Cohen of the Cleveland Clinic stated, the 2017 revisions further refine the well-established McDonald criteria and are based on new data. The appropriate application of the criteria is critical to avoiding misdiagnosis, and fundamentally, MS remains a clinical diagnosis, requiring the rigorous synthesis of imaging and laboratory data by a clinician with expertise in MS. The main, end quote, the main changes in the criteria are that in patients with a typical clinical isolated syndrome, the fulfillment of the dissemination in space, DIS criteria, the presence of the OCBs can now support the diagnosis of MS. In other words, bringing back more emphasis on the spinal taps, the lumbar puncture. This may cause a key change in the current clinical practice for many areas of the world. Cortical lesions are now included in the dissemination in time criteria called DIT. Primary progressive MS criteria have remained the same, but also now include the cortical lesions. No distinction has been made between symptomatic and non-symptomatic lesions, so that's important. Probably the one that's going to be the most controversial is the recommendation to use the presence of OCBs in cerebral spinal fluid to make diagnosis of MS in a patient with typical clinical isolated syndrome who has clinical or MRI evidence of dissemination in space. The second biggest change is now that both symptomatic and asymptomatic MRI lesions can be considered in determining dissemination in space and time. In the previous 2010 revision, symptomatic lesions couldn't be considered as MRI evidence of the diagnostic criteria. And third, cortical lesions can be used to demonstrate dissemination in space, while previously only juxtacortical lesions could be used. So Cohen warned that this recommendation should be interpreted carefully, as the ability to detect truly cortical MRI lesions is relatively limited. And fourth, specific criteria for diagnosing primary progressive MS have not changed, aside from the lack of distinction between the symptomatic and asymptomatic lesions and the fact that cortical lesions can be used. So finally, the revised criteria recommends determining a provisional disease course as specified by Lubin at time of diagnosis and periodically reevaluating it based on accumulated evidence. So going back to that and revisiting it and reevaluating is important. Cohen said that there were several proposals that weren't adopted because of a lack of evidence. While the 2016 Magnums criteria increased the number of paraventricular lesions from 1 to 3, the McDonald Revision Committee felt that the modest increase in specificity did not justify making the change. The group also declined to include the presence of optic neuritis pathology in the revised criteria, but they did acknowledge that the condition is an important manifestation of MS, and it represents an area of high priority for research. So these revisions to the McDonald criteria need to be validated in a range of other populations, including by ethnic group, age, comorbidities, and in more general neurology practice. There is also a need for further development of MRI to provide better sensitivity and specificity for determining MS pathology and a non-imaging biomarker to make the diagnosis of MS. Now, another focus of ECTRIMS this year was advancement in the treatment of progressive MS. There was a lot presented on primary progressive MS and SPMS. We can treat progressive disease, although results have been modest so far. This was an encouraging theme throughout the meeting and many presentations highlighting the emergence of new data to support the emergence of new treatment options and new coming down the line for previously untreated course of the disease. So another one that was focused on was ocrelizumab, the oratorio study, a humanized monoclonal anti-CD antibody. This was the first positive phase 3 clinical trial in primary progressive MS, showing that ocrelizumab is reducing disability progression in SPMS, secondary progressive MS. An open label extension trial was recently completed showing that ocrelizumab effect is sustained with ongoing treatment. The benefit of DMTs in older patients may be reduced, particularly in progressive MS. Okay, another trial that was focused on is the Siponimod, I almost said that correctly, expand trial. Selective modulators of the phosphate receptor significantly delayed disability progression by 26% in 6 months in patients with secondary progressive MS. Siponimod also reduced MRI disease activity and brain volume loss at 12 and at 24 months. So that was significant as well. Abutolast, the SPRINT MS trial, was focused on initial data showed that the abutolast slowed the progression of brain atrophy in progressive MS, both primary and secondary. So that was a significant revelation. Another one is natalizumab, improving the upper limb function in SPMS. Although not improved EDSS or lower limb function, natalizumab led to improvement in upper limb function, the 9-hole peg test, and in secondary progressive patients. A future pipeline. The future pipeline, the progressive MS being focused on, is in the active research area with many ongoing trials, which include MS-STAT2, SBI2, the MS SMART, as well as new molecules such as the lacutamab, masitinib, the ibutolast, and the itabenenone. So there's a lot coming down the pipeline, especially for PPMS and SPMS. So definitely keep your ear to the street on that. Now, another area of focus was new treatment options for relapsing remitting MS. So the RADIANCE trial. In a multicenter randomized double-blind trial examining ozanimod versus interferon in patients with active disease, the ozanimod was found to have a 38% reduction in annual relapse rate over 3 years compared to the interferon. In addition, secondary endpoints were met, including reduction in number of T2 lesions and reduction in total brain volume loss, gray matter volume loss at 2 years. Although there were some cardiac effects, they were relatively mild. So definitely follow up on that RADIANCE trial. Another one was the SYNERGY trial. This one was the anti-LINGO-1 monoclonal antibody. SYNERGY assessed the efficacy of opicinumab in patients with relapsing MS as an add-on therapy to interferons. The postdoc analysis of SYNERGY data presented in the conference indicated an increased effect of opicinumab versus placebo when used at the same time as the interferon in patients with shorter disease duration and lower rates of the magnetization transfer ratio, MTR, in MRI suggestive of lower myelin content. Okay, so that was also an interesting result. Also, Biogen announced that the initiation of a phase 2 double-blinded control study, Affinity, to further study the effect of ozanimod in these patients. So there will be a continuing study on that. Ocrelizumab was presented improving visual function in relapsing MS, so the OPERA studies. Ocrelizumab was associated with a significant improvement in visual outcomes at 12 weeks in RRMS patients compared to interferons. So significant improvement in visual outcomes. So that was really big news. Okay. So all the future pipeline stuff, of course, will be continuing studies. So we will bring you updates on those as they come in. Another significant topic of discussion at the conference was the need for early treatment to prevent progression. Will Brown from the University of Cambridge in a session, as well as A. Fabiatos from Melbourne, he's the winner of the Poster Award. Both presented data from MS base on the risk of secondary progression and the effect of disease-modifying therapies. Improving disability trajectory was associated with a decreased risk of secondary progressive MS, while greater level of disability trajectory and age was associated with a higher risk. So patients on all included treatments showed reduced a risk of conversion to SPMS compared to the untreated patients. Treatment within 5 years of the first relapse was associated with significant delay in the time to progression compared to later treatments. Longer duration of therapy was associated with decreased risk of SPMS. These results highlighted the importance of early diagnosis and early DMT. Finally, DMT has an impact on mortality. An international population-based study presented as a poster by E. Kingwell showed that exposure to interferons was associated with reduced all-cause mortality rates in patients with MS. On Friday, the study was presented regarding beta interferon therapies, increasing survival of MS patients, which was a long-term exposure of at least 3 years of beta interferon therapies such as Rebif, Avonex, may increase the survival of MS patients, according to this study. The findings, titled Beta Interferon and Mortality in Multiple Sclerosis, a population-based international study, was presented and stated that the body naturally produces proteins called beta interferons that play a vital role in the immune system. Beta interferons are released in the final stages of an immune attack to dampen inflammation to shut down the body's immune response. The therapies based on the beta interferons have successfully been used to treat relapsing forms of MS, including Rebif, Avonex, betaferon, Plegard, and Extavia. However, it's not clear if the betaferon prolongs survival in people with MS. So in the study, it was a team led by researchers at the University of British Columbia in Canada, and they investigated how the beta interferon treatment affects all-cause mortality by testing it in a real-world clinical setting. The team analyzed prospectively collected data from relapsing remitting patients living in British Columbia, Canada, France, and then the patient data, including sex, birth date, EDSS scores, and the disease-modifying treatments, were crossed with population-based administrative databases. Patients from Canada were also cross-referenced for drug prescriptions filled, universal health care registration, hospital admissions, and physician visits. The patients who participated in the analysis had not been treated with DMTs at the start of the study and were followed for 17 years. The analysis included a total of 7,009 RRMS patients, mostly women, with a median age of 42 years when entering the study. Researchers used as a control group up to 20 MS patients randomly selected, but matching in sex, age, calendar year, and EDSS at the study entry. During follow-up, 30% of the patients received a beta interferon therapy, 11% received Copaxone, and 12% received another form of DMT, including MS-specific immunosuppressants. Researchers then estimated how beta interferon treatment associated with all-cause mortality. The results showed that compared to patients who had minimal or no beta interferon therapy, those who had treatment for over 3 years had an increased survival rate. Exposure to beta interferon for less than 3 years had no effect on survival. So overall, the results suggest that beta interferon, IFNB, was associated with a lower risk of all-cause mortality among MS patients treated in clinical practice over an observation period of up to 18 years. The findings were consistent across 2 geographically distinct regions, including North America and Europe, so in Canada and France. So those were the conclusions on that study. Let's also focus on the study that focused on the risk of conversion from RRMS to SPMS, and that it is modifiable over 5 years with existing DMTs, more so with the high efficiency therapies, Lemtrada and Tysabri. So there was a really big focus on that in the study. They were using Lemtrada and they were using Tysabri, and wanted to show that they are more effective in preventing that conversion to secondary progressive multiple sclerosis. So they compared them to older injectable drugs. Researchers from the University of Cambridge in the UK reported this at ECTRIMS meeting. The findings indicate that SPMS is in part as a result of earlier inflammation, and that disease-modifying drugs can offset the risk of people with relapsing remitting disease progressing to SPMS. The study entitled "The Effect of Disease-Modifying Treatments on Conversion to Secondary Progressive Multiple Sclerosis" was presented by Will Brown and examined outcomes of MS patients followed in the MS-based international registry. According to Brown, there's a conflicting previous data about whether injectable therapies delay SPMS. The goal of the study was to determine whether those immunomodulatory drugs influence conversion to SPMS. They determining whether the potency of disease-modifying drugs influence the conversion to SPMS, and determine whether the timing of the immunosuppression influences conversion. So it's all about having an early intervention and whether those immunosuppressive drugs actually have an influence on the timing. So patients in the study were treated for at least 4 years with a single disease-modifying treatment, injectables, a group composed of interferons like Compaxone, along with Gilenya, Lemtrada, or Tysabri. So the analysis included only patients treated with the injectables before 2006, when more effective treatments became available to reduce the risk. That this group included people with milder disease. To explore the impact of the treatments in the progression to SPMS, they compared the patients to 622 untreated patients who had been followed for an average of 9.2 years in an earlier study. To make the comparisons more valid, they matched the patients according to sex, baseline age, annualized relapse rate, disability level, and disease duration. So that analysis showed that each treatment group lowered the risk of the progression at varying degrees. I wanted to focus really on this study because this has been highly debated. A smaller portion of the patients converted to SPMS following the treatment with Gilenya, Tysabri, or Lemtrada compared to the injectable therapies. The risk to convert to SPMS among the patients treated with injectables was 0.31, a follow-up of 7.9 years, 0.23 with Gilenya, follow-up of 4.6 years, and 0.50 with Tysabri, follow-up 4.9 years, and 0.60 with Lemtrada, follow-up for 7.2 years, compared to the matched untreated patients. The higher the hazard ratio, the lesser the risk. So when comparing Tysabri and Lemtrada, the researchers noted no difference in the risk of progression. Therefore, the team combined these two treatments as being high efficacy treatments and compared all patients receiving them to those treated with injectables. The analysis demonstrated that people on Tisabri or Limtrada had a lower risk of developing SPMS compared to the patients treated with the injectables over the follow-up period of 5.7 years. The data supports that hypothesis that the early information drives the progression to SPMS, and that had not been explored in earlier studies. So I just wanted to underscore that the risk of progression can be altered by these disease-modifying drugs. So overall, the seventh ECTRIMS meeting this year highlighted the extraordinary advancements in this field of neurology, both in terms of mechanistic insights and therapeutics. Most importantly, it brought together clinicians from across the globe in a beautiful venue, promoting further discussion and collaborations shared with the patients and with the families affected by multiple sclerosis. The 8th ECTRIMS meeting will be held in Berlin, Germany on the 10th through the 12th of October 2018, with hopefully even more exciting discoveries, and we will be sure to share those with you. And if you want to discover a more comprehensive overview of ECTRIMS, please visit our website, ECTRIMS2017.msunites.com. That's ECTRIMS2017.msunites.com. The MS Global Support Network is proud to announce our newest initiative, Multiple Sclerosis Clinical and Research Radio, coming in early November. The MSGSN Clinical and Research Internet Radio serves to build on the tremendous success of our MS&Me radio platform. This new MSGSN initiative has numerous advantages toward multiple sclerosis patient, family, and caregiver public in respect to advocacy. The MS research and clinical communities and institutions now will have an outlet towards having their work more visible, and numerous advantages that come along as a result. So they can bring that straight to us patients and families and caregivers in a way that we normally do not have access. So that will be a wonderful opportunity for both the clinical and research community and us as patients, families, and caregivers who will get information in a way that we've never had access before. So look for that in early November. The MSGSN is so proud to bring you the Multiple Sclerosis Clinical and Research Radio. If you want more information about all of our media division programs and initiatives, please visit our website at www.msandmemedia.com. That's www.msandmemedia.com. Please join me next week, and I will bring you another interview with a wonderful researcher that will soon be announced. I cannot wait to bring you that interview. See you again next week.